Thanks for joining us for another episode of our Lifetime Learning series webinars. Today we're covering an incredibly important topic for all of us eventually, which is Medicare. And before we get started, we want to let you know on this webinar, we will be taking questions at the end of the presentation. So email any of your questions either now or later to info@lifetimeasset.com, info@lifetimeasset.com. And we'll go over as many questions as we can at the end. Co-hosting today is my esteemed colleague, Matt Glover.
Thank you, Guy. It is a pleasure to be here with everyone. Like Guy said, my name is Matt Glover. I'm also a wealth consultant at Lifetime Asset Management. I'm celebrating my 10-year anniversary with the firm. I can't believe it's been 10 years, Guy. It's been an amazing 10 years. I'm sure you say the same thing every day.
Every day.
I know what a lot of you may be thinking, and that's, boy, Matt looks good for the lack of sleep that he has been getting with this newborn baby. I know that's what everyone is thinking. I'm just kidding. It is. I do have a newborn, and he's been giving us a quite a time the last couple of nights with lack of sleep. But I'm sure instead of thinking how amazing I look on video with the lack of sleep, you guys are all thinking Medicare is a complicated issue, and it certainly is. And we're very thankful to be able to put on these sessions and host some subject matter experts. And so we appreciate Joe being here, and I'll introduce him in a second, or I'll have Guy introduce him in a second. But we want to make sure that you know that the session is being recorded. You can rewatch this as soon as we get it posted. You can share it with friends and family, and keep an eye out on our website for additional information as we get it out to the public. So our speaker today is Joe DeMartino, and Joe is a Medicare and individual health insurance consultant with Marsh McLennan, the agency here in Raleigh. He spent 7 years with Blue Cross Blue Shield of North Carolina and has had a VP role as a marketing and account director with several other agencies. He's received his MBA in marketing from Cornell University, Bachelor of Science in finance and economics from the University of Connecticut. And without further ado, let's get started. Guy, you ready to kick us off?
Absolutely. Just like Matt, I know all of you are looking at me and saying how great I look, considering that I've been on Medicare now 3 years as of this month. So I'm familiar with Medicare. Obviously, I've been on it for this 3-year period of time, and I've got a few observations. First of all, it's great coverage for the cost, in particular when you were paying well over $1,000 prior to Medicare. Secondly, is complex. In fact, recent polling suggests that the vast majority of us on Medicare do not understand it and all of its components. And the third, and something that all of us that are 65 and over experience every year, we get the opportunity to become every insurance company's best friend, because the advertisement starts rolling in during this open enrollment period. And we get dozens upon dozens of calls and mailings, and it becomes, I think, even more confusing with all of that. So Joe, you're gonna make it simple for us. You're gonna clear up all of this confusion, right?
That's exactly what I'm gonna do. And
Great.
let me go right to there. Can you see everything?
Absolutely.
All right, hey folks, thank you for joining. Today is kind of an auspicious day because it is the beginning of the Medicare open enrollment period, which if you are not on Medicare doesn't mean a thing to you, and it doesn't need to. If you are on Medicare, it means it's time to shop and see if you want new plans for next year. I know this is the case because my phone started ringing off the hook, and you know, the emails have been going crazy. So that's redundant, but let's go right here. So the goals for this session, we're gonna take about 30 minutes. And you're not gonna be a Medicare expert when we get done. I don't even consider myself a Medicare expert. I know a lot about it, and I know where to find the answers, and that's sometimes all you need. It is complex, but my goal, hopefully, is to break it down so that you understand at a high level you've got some options. You can go this way, you can go that way. There's a few different things. Once we go through this, I hope you'll at least be able to understand or have more information on the different basic parts of Medicare. What is a Medicare Supplement plan? What is a Part D drug plan? How do they work? What is this thing called the Medicare Advantage plan? When do we enroll? And then we'll have some questions and answers. So before we get started, I just want to say, this is what's called an educational meeting, educational only. So I cannot discuss individual plan details. I can't talk about a specific product. That doesn't mean I can't tell you how they work. I just can't pull up, quotes for different products and things like that. I can't ask for or receive an application. I am available for follow-up. If anybody wants to have a conversation, you have to call me. I cannot and will not make unsolicited calls. And please never, ever pay for Medicare counseling. There is just so much free and advice that's out there. I think it's more important to find somebody that you feel comfortable with and go from there. But if somebody says, yeah, I'll help you out, but it's going to cost money, that's a big, big red flag. Here's the most interesting thing, I think. All information is current as of plan year 2020. Medicare is a calendar year plan. So everything changes come January 1st. So you might say, gee, Joe, do we now know what 2021 is going to look like? And the answer is not entirely. And the reason is because Medicare rates and benefits are set after the federal government passes the budget and everything goes through the process. We find out typically in November, December. Some information we don't even find out until January. Everything that you're going to see here is current for 2020. I didn't try to find, here's what's going to change in 2021. Here's what's 2020. This should give you an idea of the order of magnitude of what things look like. All the numbers that you're going to see here are going to change for next year, but they typically don't whipsaw. They're not going to go crazy. But order of magnitude, if you're just saying, well, what's Medicare going to cost? I think you'll be able to get through that today, okay? So let's get right into it. What is Medicare? It's a government health insurance program for folks who are over 65 and people who are under 65 with certain disabilities. If you've been on Social Security disability for 24 months, you become Medicare eligible. If you have end-stage renal disease or ALS, Lou Gehrig's disease, you become Medicare eligible. That's who Medicare is for. Started in 65 through the Social Security Act, 65. It seems like a long time ago, but that's, by 66, there was 19 million members. In 97, we had the advent of Medicare Advantage plans. And in 2003, we had the introduction of Part D plans. In 2010, the Affordable Care Act changed Part B premiums and Part D coverage. And I guess the big question is, what happens next, right? We're in a contentious environment in Congress, and this is a big dollar. There's a lot of money in Medicare. And so it's frequently, people are trying to figure out, are we spending too much, not enough? So, if you were never watching what was going on in Congress before, now you might want to start to a little bit, because this is going to have real effect on us, all of us going forward. There's 67 million Medicare beneficiaries now. There'll be 80 million by 2030. If you're moving into Medicare, you're going to find yourself in good company. So Medicare is an alphabet salad. Everything has a letter designation. And we're going to go through what is Part A, what is Part B, Part D, Part C, what's a Medigap plan. We're going to go through these one at a time. Part A and B are commonly referred to, and I refer to them as original Medicare. So if I say original Medicare, that means A and B, okay? So Part A of Medicare, it covers inpatient care in hospital. If you are admitted, that's the key word, admitted to the hospital, you will pay $1,408 in a deductible each time you're admitted to the hospital, with a couple of exceptions. If you are released from the hospital and within 60 days you have to be readmitted because of the same condition or complications from your previous visit, you do not pay another deductible. If you have complications on day 61 and you got to go back to the hospital, you pay a deductible. You can be in multiple benefit periods if you've had to go to the hospital and get admitted more than once in 60 days for completely unrelated things. So the biggest difference between Medicare Part A and any kind of health insurance company that, or health insurance that you've had, is that this is Part A, the hospital part, is not, the deductible is not for the calendar year. It is per event. That deductible carries you for whether you're there one night or up to 60 nights. It also covers some inpatient care at skilled nursing. So if you find yourself coming out of the hospital, you need to rehab for the first, couple of weeks, 3 weeks. Medicare covers that at no cost. If you need to be in skilled nursing beyond that, you pay $176 per day. This is not long-term care. This is not a nursing home situation. This is, I need to rehab before I can go home after a hospital visit. Part A also covers hospice care services and some limited home health care services. So that's not going to be the doctors coming to your house, but it might mean once or twice a week, somebody comes over, makes sure you've been taking your medication, takes your blood pressure, checks your vitals, that kind of stuff. So that's Part A in a nutshell, okay? What does it cost? It doesn't cost anything. And to Guy's point earlier, he said Medicare is a good value, and it is. And it's primarily a good value because you've paid payroll taxes your entire working life. Most people, if you or a spouse have worked 10 years or 40 financial quarters, you get Part A at no cost. If you had to buy it, and a lot of people do, it's $458 a month. So people refer to it as free. I can't do that. It's not free. You already bought it. You paid for it. Your monthly cost is $0, but it's not free. Part B of Medicare covers a whole host of things that they call medical services. So this is going to be your doctor visits, these are specialist visits, home health care, durable medical equipment, outpatient care, outpatient surgery, tests, x-rays, imaging. All of these things go into diabetic supplies. All of that goes into Part B. And Part B generally pays 80% of the expense after a small deductible. This is a calendar year deductible. This year it's $198. So the first time you go to the doctor, you pay $198. After that, Medicare is going to pay 80% and you're going to pay 20%. There is no maximum annual out-of-pocket on either A or B. And that's another big difference between group plans that you might have had and what you'll see in Medicare. The Part B premium, again, this year is $144.60, but the premium is higher. And they're going to look back 2 years. So in 2020, they're looking at your 2018 household income. In 2021, they're going to look at your 2019 household income. And this year, if you were single and earned over $87,000 in 2018, or married and over 174 in 2018, you will cost you more. And if I did this right, here's the chart. Okay, so what you see here is that if you are, if you are at that base rate, you pay $144.60. And if you're, higher up, you go up. And I'll get to what the Part D income adjustment is when we talk about Part D plans. But you'll notice, if you're up there, it does get rather expensive. Okay. But keep in mind that it's always going to be a 2-year rolling look back. So if you go into retirement and your income might come down somewhat, you will end up, in a lower bracket over time. Again, always 2 years looking back. Okay. So when I have Part A and I have Part B, I've got about 80% coverage for medical expenses. Hospital expenses, it's hard to do the math, but that's a $1,408 deductible every time I go. But there's no maximum annual out-of-pocket, and there is no prescription drug coverage. Part B does cover infusion drugs that are administered in a provider setting. So that could be chemotherapy. It could be, any number of drugs that are done through infusion at a provider setting. That will be covered under Part B. But all of your, pharmacy medications that you pick up at, Walgreens or whatever, that's not covered under original Medicare. So what do we do about those two problems? How do I provide a safety net? How do I get my prescription medication? And there are two paths for most people. The people who have something different would be folks who have VA benefits with prescription medication, or some folks have retiree plans that have prescription medication. If that's the case, you are in a slightly different situation. And if that's the case, we can talk about that one-on-one. But for the most part, most people are in one of the following two paths. They both start with I enroll in Medicare Part A and Part B. And then on the one hand, I either add a Part D plan for prescription drug coverage and maybe a Medicare Supplement, or what is called a Medigap plan, 2 words, same exact thing. Or I enroll in a Medicare Advantage plan that combines hospital medical prescription drugs all into one. There are some Medicare Advantage plans that don't cover prescription drugs. And again, that would be for somebody who has prescription drug coverage through, say, the VA or an employer. But those are the two paths that most people are going to take. So I'm going to go through each one separately. Start off with Part D drug plans. So Part D drug plans are drug coverage run by private insurance companies that are contracted and approved by Medicare. This year in North Carolina, we have 11 companies that are selling 28 different plans. And, a lot of times when I tell people that, their eyes roll and say, well, how do I figure out, which one's best for me? And I'll say this, having 28 options is a good thing. I can tell you that for 2021, we've got 31 or 2 options. It's an even better thing because everybody has a different list of prescription medication that they're on. And all these drug plans have different formularies. All the plans have to have a certain number of drugs in what they call each therapeutic category. So if you find yourself, we pick a plan based on the drugs that you're currently taking. Then the year goes by and you've got to see the doctor, and the doctor says, well, you need another prescription. So you can't guarantee that the drug that the doctor is going to default to is going to be on the formulary of the plan. It may well be. But if it's not, understand that there are what they call therapeutic equivalents. And so there's not going to be any situation where I've got a Part D plan, my needs change during the year, because when you sign up for a Part D plan, it's for the calendar year, except in very few circumstances. So what you can know is that no matter what you might be diagnosed with throughout the year, your Part D plan is going to have some number of therapeutic equivalents for, every category. The average monthly premium is about $35 this year. The least expensive plan is under 15. The most expensive plan is over 110. The premium amount does not indicate quality. If you pay more, it doesn't mean that there's a bigger formulary behind the scenes. It doesn't mean, all these plans are different. And so what we do is, I do this for my clients all the time. I ask for a list of their prescription medications. I don't care why they're taking them. I just need to know what they are. I can go to Medicare.gov, as can you, and put those drugs in anonymously if you want. And there's a tool that will rank and sort the 28 plans that we have in North Carolina or wherever you might be living. And it will show you which plan, what your cost would be under each of those plans, assuming your drug list doesn't change and you get everything refilled all the time. And so what I'm looking for is, you know, a client might come to me with half a dozen drugs. All right, of the 28 plans, maybe 14 of them have all their drugs on the formulary. Great, I don't have to worry about the other 14. Now I can dig into things like, okay, well, what's the premium? Is there a deductible? How much will it cost to get me each of those drugs? And then we can finally look at things that, you know, may or may not be important to you, but, you know, is my favorite pharmacy a preferred pharmacy? And if you don't mind going across the street, that's fine. But if you want to stick with the pharmacy you have, we can factor that in as well. There is a monthly premium surcharge with those for higher incomes. So I'm going to go back just a second here to this slide. And you can see that in addition to paying a higher Part B cost, you will have to pay what they call an income-related adjustment amount each month if you are above that threshold. And that money, all this money goes to the Social Security, the federal government. So this is not going to go to the private insurance company, it goes to the federal government. And that's why it says, you know, $12.20 plus plan premium. So whatever plan you pick, if you're in that first bracket after the 174, you'll pay an additional $12.20, okay? So let's go into how these plans work. Some drug plans have an annual deductible. In 2020, that deductible cannot be more than $435. Then there are drug tiers, and different plans can have different amounts of tiers. It could be a 4-tier plan, it could be a 6-tier plan. And it's typically tier 1 is going to be your preferred generics, tier 2, non-preferred generics, tier 3, preferred brand, tier 4, non-preferred brand, and tier 5 or 6 would be specialty drugs, okay? So for each of those tiers, you will pay a different amount. For some plans, for a lot of plans, the deductible does not apply to tier 1 and tier 2 drugs. So if you are on kind of the generic or inexpensive maintenance medication, whether it's for cholesterol, high blood pressure, you know, diabetes, whatever, if you're on those maintenance meds, oftentimes you're going to find out that they are tier 1 or tier 2. The deductible doesn't apply. It's only going to be drugs in tiers 3 and above. So once you've satisfied the deductible, and not all plans have a deductible, but once you satisfied that, you then have co-payments based on drug tiers until the drug costs, not what you pay, but the actual cost of the drug reaches $4,020. Yeah, it seems like a lot, but I can tell you there's plenty of medications that in 1 month, that's more than $4,020. After $4,020, you get to what's called the gap or the donut hole. And at that point, you pay 25% of all prescription drug costs until you reach $6,350 in what they call out-of-pocket costs. But keep in mind this, it's really not out-of-pocket costs, because if you take brand name drugs, even though you're only paying 25% of the cost while you're in the gap, the entire amount of the drug is added to your out-of-pocket. So if you are taking prescription medications that's brand and it's expensive, yes, you're going to end up in the gap, but you're also going to get out of the gap faster because they're going to add in the other 75% that you're not paying. If you happen to reach $6,350 in out-of-pocket costs, you are then what's called the catastrophic level. And at that point, you're either going to pay $3.60 for generics, or $8.95 for brand name, or 5% of the total drug, whichever is more, for the rest of the calendar year. and then everything starts all over again January 1st of the following year. Okay. So that was Medicare, a Part D drug plan. That covers your drug plan, your drug coverage. But what about the expenses that Medicare Part A and Part B leave behind? And this is where Medicare Supplement plans, these are also called Medigap, interchangeable. And we'll go through that now. So Medigap plans are run by private insurance companies. They are standardized benefits. There are 11 plan designs, and those plan designs are going to be the same whether you buy it from Aetna, Cigna, Blue Cross, Humana, United Healthcare. It doesn't matter. There might be reasons why you would prefer one over the other apart from the cost, and we can talk through that in a little bit. But as far as the benefits that are offered, they are the same. And all these Medigap plans have, they are called by letters. And so Plan G is the most comprehensive that's out in the market now. For a 65-year-old, premium is going to be about $110 plus or minus. And with Plan G, you pay your monthly premium. You will have to satisfy your Part B deductible, Part B being medical insurance. That deductible, again, is $198. And then Plan G is going to pay all of your remaining Medicare-approved expenses, hospital or medical, for the balance of the year. Okay, Medigap plans do not cover prescription drugs. They used to, they don't anymore. So that doesn't apply to your prescription drugs. That's handled under Part D. But this is for your hospital and medical expenses. There's also something called high deductible Plan G. It's one of the lowest cost options. For about $40 a month, you have a plan that will, so Medicare will pay first, and then you'll have what I call a corridor deductible. It's not the first dollar because Medicare is paying, but then you'll have a $2,340 deductible. And if you hit that deductible, then the plan will pay, again, 100% for the remainder of the calendar year. So, you know, I always tell my clients, if you can tell me exactly how you're going to get sick next year, I can tell you exactly which plan you would have wanted to have been on, but not one of them has been able to tell me that yet. But those are sort of the bookends. Plan G is the high end. High deductible Plan G is still, it's the same coverage, but with a higher deductible and a lower premium. Medicare Advantage plans are not network plans. You can go to any doctor or hospital in the United States, and as long as they accept Medicare, they will happily accept your Medicare Supplement plan. Some plans include foreign emergency coverage. Better than nothing, but if you're going to go spend a long time out of the country, you should consider buying a supplemental travel plan. So just keep that in mind. But there is some amount of foreign emergency coverage. And Medigap or Medicare Supplement plans are guaranteed issue when you first come into Medicare. So when you first come into Medicare, they're not going to ask you any questions. Everybody gets accepted. If you don't join Medicare when you are first eligible, what you'll find is you can still submit an application, but you have to answer health questions. You have to go through underwriting, and you can be declined. So, you know, this is one of those things where if you wait until you need it, you might not be able to get it. And that's frustrating for people, I know, but that's just the lay of the land. Okay. So back to this slide, we just talked about the left hand, right? I've got A and B, and now I've enrolled in Part D and a Medicare Supplement plan to fill the gaps. The other is to enroll in something called a Medicare Advantage plan. And so we'll talk about that, also called Part C. So Medicare Advantage plans came out in the earlier slide said 1997, and this is the first attempt of privatizing Medicare in a sense. The idea is that a health insurance company really ought to be able to manage the health of a population better than the federal government. And so with a Medicare Advantage plan, a private insurance company that is contracted with Medicare takes over your Medicare benefits, replaces Medicare A and B, and includes benefits for hospital, medical, and drugs all in one plan. It also has a maximum annual out-of-pocket, which applies to hospital and medical. It uses a specific network of providers, HMOs, meaning you have to stay in network. PPOs, you can go in or out of network, but it's going to cost you more if you go out of network. And these are also guaranteed issue when you first enroll in Medicare. And then there's an open enrollment period every year. Like I said, it started today, October 15th through December 7th. That's the shopping period for when you can put an application in for next year if you want to change plans. You'll find that Medicare Advantage plans have lower premiums. Many of them have $0 premiums, even though you still have to pay your Part B. Some plans have local networks, others are nationwide. So you have to at least be cautious about what you are buying, make sure you understand what your network is. And the way it works is that the federal government will reimburse the private insurance companies on a per member per month basis. So if you've got a member enrolled, maybe it's about $800 plus or minus per member per month that the federal government is going to send to the private insurance company that you enrolled with. And it is their job to manage the health and happiness of the population. If they do a better job, their star ratings, there's a star rating, 0 to 5. If they do a better job and their star rating goes up, then so does their the amount of money they receive from the federal government. And they can turn around and add things that are not part of original Medicare. So Medicare A and B, the supplement plans, the drug plans, none of those cover dental, vision, or hearing. Apparently Medicare just hadn't gotten there yet. I'll put it that way. So, a lot of these Medicare Advantage plans, for example, as they've shown a link between dental health and physical health, Medicare Advantage plans started saying, hey, you know what? It's not dental insurance, but we'll give you an allowance, might be $300, might be $1,500, depends on the plan, every year. And if you need dental services, you go and pay, you send it in to us, we'll reimburse you some amount of money. Same with vision, might have a $200, vision allowance. Again, not insurance necessarily, but if I need glasses, which I do, I go in, I pay my money, I send it in to the plan reimburses me. Hearing as well. So there are some nice benefits that are in Medicare Advantage plans that you will not find in Medicare Supplement plans. Also keep in mind that this is what you would call managed care, okay? Medicare Supplement plans, you don't need a referral to see anybody. Even on Medicare Advantage plans, you don't need a referral sometimes. But with Medicare Supplement plans, it's the Wild West. If you want to see a doctor, the doctor takes Medicare. That's all you need to do. With a Medicare Advantage plan, you're going to have, if you find yourself with a chronic condition, you'll get some calls from the health insurance company because they want to make sure you're taking your meds, your house is set up for your needs. They want you to be healthy and happy, because if you're healthy and happy, their reimbursement rates go up, the premiums go down, they add extra benefits, okay? And again, these have been around since '97. At this point, there is roughly a third of Medicare beneficiaries have a supplement plan, a third have a Medicare Advantage plan, and then there's a third that just haven't really done anything. So think about being in the first 2/3. No, don't go down the path of not doing anything, please. I don't mean to put up an eye chart. I thought it'd be instructive to see, okay, how does original Medicare work again? How does that Medicare supplement with a Part D work again? How does the Medicare Advantage plan work again? Because this is where you can really see how things are different. So we talked about how if you have original Medicare, you go to the hospital, there's a $1,404 deductible. With your Medicare supplement plan, There is no cost after you meet your deductible, whether it's Plan G, where the deductible is $198, or high deductible Plan G, where the deductible is $2,340. Once you've satisfied your deductible, the rest of your hospital expenses are going to be covered. Medicare Advantage plans do something differently. They will select some number of days and some copay dollar amount, and they'll say, well, okay, if you're in the hospital for, for the first 3 days you're in the hospital, we're going to charge you $300. Or for the first 6 days you're in the hospital, we're going to charge you $250. But if you're still in the hospital after that, the rest is on us. I like this a lot because people don't tend to stay in the hospital for days and days and days. Yes, it happens. But for the most part, they get you in, they get you out. So why would you want to pay a $1,400 deductible that's going to last you, whether it's one night or 60, when you could pay, $250, $350 for a couple of days? So that's the biggest difference between original Medicare or even the supplement plan and a Medicare Advantage plan, is the hospitalization. With primary care, specialists, all that other stuff that you see down there, Medicare Part B, it's 20%. You pay 20% after the deductible. With your Part D plan, there's no charge after your deductible. Again, you kind of pick the deductible you want. And with Medicare Advantage plans, you see a lot of copays. So they don't typically charge you percentages. They just say, well, if you're going to go to a primary care doctor, it's going to be $0, $5, $30. You're going to go to a specialist, it could be $50. There is a maximum out of pocket that applies to medical and hospital only. It's typically in the $3,000 to $5,000 range if you stay in network, and it's typically about $10,000 combined if you go in and out of network. Original Medicare and Medicare Supplement, they're not networks. Anybody that accepts Medicare takes your plan. Medicare Advantage plan, again, they do have HMOs, PPOs, something called an open access PPO, where you can literally go to any provider. But again, you will pay more for going out of network. Original Medicare does not cover prescription drugs. With the supplement plan, you'd have a Part D add-on. You'd have the deductible, the copays, the percentages. Same with the Medicare Advantage plan, except in there it's embedded. And then for additional benefits, Medicare doesn't have additional benefits. Some supplement plans offer gym memberships and discount programs. And some Medicare Advantage plans offer gym discounts and allowances, as I said, for dental, vision, hearing, and even some other stuff that's not on here. Okay. So how do you choose? And I will tell you, I don't think there's one best solution. It comes down to, what are you trying to accomplish? Am I trying to limit my monthly expenses? If you are, you're probably going to look at either a high deductible supplement plan or a Medicare Advantage plan, lower premiums. If you are trying to have the most access to providers that you could possibly imagine, well, then you're looking at a Medicare Supplement plan. If you're comfortable with a network of providers, and if you live in a urban area or even a suburban area where we've got a lot of providers, the networks are broad. It's when you go out to the coast or the mountains where you might find that the network's a little narrower. So, are you comfortable with a network? Will you be traveling nationally or internationally? If you're going to spend half your time in Florida and half your time in North Carolina or whatever, you need to make sure that if you buy a Medicare Advantage plan, it has coverage in the state where you're going to be spending, half your time. And then, do you want extra benefits not part of Medicare? And sure, everybody does, but how much is that worth to you? So when I work with my clients, it's just a matter of kind of going through these and trading things off. I would like the most for the least. I'm sure you would too, but we make trade-offs and we decide. And that's really it. I mean, I wouldn't say anything bad about a Medicare Supplement plan. I wouldn't say anything bad about a Medicare Advantage plan. They are different tools to manage your risk. And that's really it. Okay. So when do you enroll? And there are several enrollment periods. When you first turn 65, you have an enrollment period. When you leave group coverage after age 65, you get a special enrollment period. If you've been on Social Security disability for 24 months, you get a special enrollment period. And you can enroll in Medicare through the Social Security Administration. You can do it online. You can't go to the offices right now. The offices have been closed since March, but you can do it over the phone. You can do it online. So when? If I'm going to retire at age 65, I got all my ducks in a row, turn 65, that's it, I'm out. You have a 7-month period surrounding your 65th birthday in which you can enroll in Medicare. The 3 months before your birthday, the month of your birthday, the 3 months after. That's called your initial eligibility enrollment period. I get a lot of calls every year from people who are turning 65 and say, I've got to do something, right? Not necessarily. If you're covered under a group plan, which we're going to cover next, you can defer Medicare and not get penalized. The penalties in Medicare come when you go more than 2 months after age 65 without insurance. If you go more than 2 months after age 65 without insurance, you are going to start having late enrollment penalties, waiting periods, that kind of stuff. But again, there are a number of enrollment periods, and we'll go through some of the others in just a second. So if I've enrolled in Part A and Part B, then I, at the same time, can enroll in either a supplement, a Medicare Part C, a Medicare Advantage plan, or a prescription drug plan, and a Medicare Supplement plan. I can pick that up within 6 months of becoming Part B eligible without answering health questions. If I wait until month 7, I can still buy one, or at least I can still submit an application. But if I can't answer the health questions, I can be declined. Okay. So let's go to the more common issue, which is I'm working past age 65. So now you've got some choices. Okay. If you are at a company with more than 20 employees, you can defer your Medicare Part A and B for as long as you have what they call continuous creditable coverage. And as long as you do, and most group plans are creditable coverage, Medicare doesn't care if you don't come in until you are age, 130. They don't. They just want you to be insured before you come to them. So if you want to work into your, late 60s, 70s, 80s, you could stay on your group plan, and defer Medicare without a problem. You'll have a special enrollment period. Okay. So when you go through that special enrollment period, and it lasts for 8 months after your employment or group coverage ends. Doesn't mean you have to wait until your coverage ends to get your coverage with Medicare started. It just means that if you leave a group plan after age 65, you've got up to 8 months to get your Medicare ducks in a row. Once you do that, again, you can enroll in a Medicare Advantage plan at the same time, or a Part D drug plan. With Medicare Supplement plans, now you have 6 months following your Part B eligibility date to have guaranteed issue, or 2 months after your employer or union coverage ends. So if for some reason you found yourself working and having Part D coverage, you still get a special enrollment period of 2 months after you leave employer coverage to get a guaranteed issue for a Medicare Supplement plan. All right. Here's where people run into problems. And again, just don't go 2 months without being insured. If you go more than 2 months and you didn't join a Part D plan when you were first eligible, and you don't have other creditable coverage, and note that COBRA is not considered creditable coverage once you are past age 65. So if you are leaving a job and you wanted to do COBRA, if you had to do it for 1 or 2 months while you got everything else taken care of, that's fine. But you cannot extend COBRA beyond that, or you'll get a late enrollment penalty. And that penalty is 1% of what they call the national base beneficiary premium, which this year was $33.19. And that's for each month that you have gone without coverage. So this year, every month you go without coverage, they're going to start adding to your late enrollment penalty 33.19 cents per month. So if you go 10 months, you are now looking at a $3.32, call it $3.32 late enrollment penalty, and that will be assessed for your entire life. They don't fool around. They don't say, hey, you only went a year without coverage, so we're only going to give you that penalty for a year. No, it's for the life of the plan. And you're also going to face waiting period before coverage begins. So clients come to me and say, well, gee, Joe, I don't want to take prescription drug coverage. Why do I want to pay for something? I don't take prescription medications. Fair enough. There are plans that are under $15. In fact, next year, there's a plan that's under $10. We enroll you in the least expensive plan, and that prevents you from having a penalty. It also gives you the reassurance of knowing that you've got drug coverage if you need it, because you cannot make a selection in the middle of the year. You pick a drug plan, you're stuck with it for the year. So that's my advice for people who are not taking prescription drugs. Don't buy an expensive plan. You don't need it. Buy the minimum just so you don't get fined or penalized. We are just about to wrap up, and then we can take questions. So if I'm working, am I required to take Medicare? No. When you leave a group plan as an active employee, you will have a special enrollment period. No penalties, no waiting periods. So then the question is, I've turned 65 and now I've got options. Do I stay on the group plan? Do I add Medicare to the group plan? Do I just switch over to Medicare? And I'll say this is something that there's no hard and fast rule. Most people, when you do the analysis, stay on a group plan, but some have said, hey, I think I can do better on Medicare. So it is an individual decision, and I or anybody else who's qualified to do this can help you work through the plans. Some people have Part A. Again, it's no cost. It's not free, but it's Part A. And they also have a group plan, and that's fine too. If you have more than 20 employees, your group plan is going to be first. If there are fewer than 20 employees, Medicare will pay first. And that's all that matters there. If I take Medicare, do I have to take Social Security? The answer is no. But if you do take Social Security, they will enroll you in at least Medicare Part A. And I bring that up because, next question, can I have Medicare A and or B and stay on a group plan and contribute to a health savings account? No. Once you are on any part of Medicare, you may no longer make contributions to an HSA, nor may your company make a contribution on your behalf to an HSA. So just know that. And if I stay on the group plan and delay enrolling in A, B, C, or D, we'll have to pay a penalty. And again, no, just don't go more than a couple of months without, and don't even do that. Set it all up before you leave. It's a pretty quick process. The longest part of this is getting your enrollment through Social Security, and that takes about 2 or 3 weeks. And can I be declined supplemental coverage? Yeah, I think we've gone through that. If you don't enroll when you first are eligible, you can, in certain circumstances, be declined coverage. So resources, again, don't ever pay anybody for Medicare advice. Here's a whole bunch of resources, including myself. Anybody who's on here is welcome to have a copy of this presentation. Just reach out to Matt or any of the folks there. And I think that brings it to an end. So why don't we go and see if there's any questions.
Fantastic, Joe. That was, we've seen a lot of presentations over the years on Medicare, and the slides are excellent. I'm so glad we have a copy that we have access to, and your presentation was outstanding. And this is the reason we started this Lifetime Learning series. We certainly are passionate about financial literacy. And this is, I think we've had a handful of these now, and it's very consistent with one of our mission statements in Lifetime Asset Management. We really appreciate you sharing this information with us.
My pleasure.
And I'd like to start the question if I can. Let me back up one other tidbit of information for everybody on the webinar. Remember that we're making this available to all of our clients as well as any of your friends and family. So when you get an invite, if you feel like someone else would benefit from this, send them the email and they can register as well. Now, I'd like to ask the first question if I can, Matt. I know you have others.
Yeah, go ahead.
Irma. I don't like that lady, Irma. So the
income-related monthly adjustment amount?
Absolutely. So we have been told by some that Medicare will allow you to have a one-off exception. If, as an example, you sell a property or you have a peak of income, that in some cases they will come back and make the adjustment as if that was not a part of it. Is that true?
It is not automatic, so you do have to proactively reach out. I don't know what the success rate is, but I do know that, I've had an awful lot of people say, I sold a business one year, or I sold, a piece of property, and everything ballooned. So yeah, if you can show that you've had sort of a one-time extraordinary year, then I've certainly had clients who have had that remediated in full or in part. It's not going to happen automatically. You've got to have to reach out and make that happen.
Thanks.
All right, I got a couple questions that we can get in before the end of the hour here. With all the talk about pre-existing conditions and Affordable Care Act, why do they still use pre-existing to restrict you from changing Medicare plans? Aetna has a long questionnaire and will tell you that a yes answer on a certain question will disqualify you.
That's a great question, and I can tell you that the Affordable Care Act, although it did make changes to Medicare, and the big change on the non-Medicare side was, in fact, getting rid of pre-existing conditions. It did not do anything about pre-existing conditions while you are on Medicare. So, again, if you think you want a supplement plan, my advice is get into it early, because by the time you need it, you might not be able to get it. There's still Medicare Advantage plans out there, and those aren't bad. Lower cost, a little lower coverage, but still kind of in the rings. But yeah, they did not make that change for Medicare, and I have not heard any of our regulatory people saying that that's even in the cards.
Okay. Part B and D income limits, is that referring to gross income, adjustable gross income, or taxable income?
The exact line on your tax form is modified adjusted gross.
Modified adjusted gross. The the employee 20-person limitation, how does that relate to if a company has less than 20 employees but are part of a PEO?
Yep. All right. If you're part of a PEO and there are more than 20 employees across the PEO, it's treated as though it's a group with more than 20. But if you are legitimately in a group that has 20 folks or fewer than 20 folks, what you might find, and this is going to vary based on everybody's situation, or every situation tends to be different. There are some small group plans that assume, they call it phantom coordination with Medicare. They will assume that you are enrolled in Medicare Part A and B. And if you don't enroll in A and B, you're not going to get penalized when you do enroll in A and B, but the health plan is going to pay as though Medicare was paying there first. So you're going to find that you're going to have a lot of expenses if the plan requires you to enroll in Medicare at age 65. And if they do, that should be made clear to you by HR or whatever. But if you're in a small company and you're getting close to retiring or Medicare, I would reach out to the HR folks and ask the question, will I be required to enroll in A or B in order to maintain the same level of benefits? They cannot force you to drop the group plan. They can't incent you to drop the group plan. If you don't want to go, you can have that group plan. But if you're under 20, just know that you might have to pick up A and possibly B to have the coverage that you thought you were going to have. And at that point, depending on what it costs you to keep that small group plan, you might find that transitioning to Medicare completely makes a lot of sense. And this is a case-by-case thing. We just got to run through the numbers. And like I said, I'm more than happy to be doing that for folks. And
from a medical inflation standpoint, when, on the financial planning side, when projecting out the cost of care and Medicare, the cost of Medicare and long-term care and healthcare expenses, do you have any comments on what an inflation rate we should be attaching to these costs when looking at the next 20 to 30 years of retirement projections?
Wow, that's tough. I'll give you an answer. I'm going to tell you why it's a hard question to answer. Yep. 20 years ago, prescription drugs didn't account for 10% of medical costs. Now they are about 35, can be 45% of medical costs, just prescription drugs. So I think a lot of it is going to depend on, we don't go to the hospital as often. We go to outpatient places. Everything is being kind of pushed down. But as drug prices, we've got fantastic drugs. They come at a high cost. And I think that's going to be the driver of increases in Medicare. That said, when I look at a well-managed Medicare Supplement plan, well-managed, meaning a big book of business, they're not playing any games, they're just saying, here's what it is. I would go, now, and again, Medicare Advantage plan is hospital and medical, it's not drugs, but I would assume a 8% medical inflation rate. For prescription drugs, that's very hard because it depends on what drugs you're on. We've actually been seeing the premiums for prescription drug plans fall, but the premium is a small amount compared to your costs at the pharmacy. So I think, what you're going to see is your premiums probably aren't going to go up at that same 8% rate for drug plans or for Advantage plans, but your costs when you go pick up your medications, unless that's, sort of the next area that they focus on to drive down costs, that's going to be the biggest driver. And I can't even begin to peg what that's going to look like. Better
to be cautious and project a higher growth rate for some of these items.
I would think so. Yeah, I would think so. Medicare Advantage or Medicare Part B premiums and the IRMA, the income-related monthly adjustment amount, those get a little tricky. This year, we're going to have a situation where people who are already on Social Security, if you are collecting Social Security, you will be held harmless so that your increase in Medicare premiums, Part B, will not exceed any increase you get from cost of living adjustments on your Social Security. So that means that everybody who's already accepting Social Security benefits is going to pay a lower amount next year than people who aren't, because if you're not on Social Security, you're not being held harmless. And the other people who aren't being held harmless are the people in the higher income brackets. So I've seen over the last couple of years, the higher income brackets, there seems to be more getting shifted down those, especially in the higher tiers.
Okay. And we're coming up on the end, so I'll I'll finish it with, from our side, from a financial planning side, and talking about retirement projections and how some of this plays a role. Obviously, everyone's situation is different. They have to make the right decision on what type of plan to get, and professionals like you can help them choose those plans. When it comes to some of these income thresholds and paying some of these surcharges, there's a lot of planning that can be done ahead of time before they reach either age 65 or when they don't have a choice on taking income from required minimum distributions and could have a surplus in income that they don't necessarily need. And so for the audience out there, making sure that you plan ahead while you have the options to do Roth conversions, to think about taking money out of your IRAs to live on before required minimum distribution age, or doing qualified charitable distributions to keep income low, are important decisions that have a pretty long-term effect on the cost of Medicare and other items as well. So Joe, we want to thank you again for answering these questions and taking the time on open enrollment day. Today is the first day, and I'm sure you are chomping at the bits to get to your backlog of emails and voicemails.
My phone's been ringing off the hook since I've been on here, but that's fine. I enjoy doing it. And again, anybody feel free to reach out. If you've got any additional questions, I'm happy to help.
That's great. And so for anyone out, what's
sleeping.
that?
You look great for not sleeping that.
I almost fell asleep on the for anyone that has any questions, reach out to us, reach out to Joe. You have our contact information, info@lifetimeasset.com. You can email that directly as well. This is part of our Lifetime Learning Series. We have more to come. Our current schedule is the first and third Thursday of every month. We have a new topic. We try to keep it timely, like Medicare open enrollment, end of year tax planning, things like that. Keep an eye out on our website and emails for the next group of webinars, and the next one is actually year-end charitable planning, charitable giving. We have a guest speaker, Heather Zach, which is a team lead of advanced planning at our broker-dealer Commonwealth. So we'll be looking forward to having that conversation. End-of-year tax planning coming up as well, and so keep an eye out on the website for all of that. Again, special thanks to Joe and Guy for hosting and being our guest. And as a reminder, we'll get this recording out to everyone very soon. So everyone stay safe out there, and we'll talk soon.